Good morning, dear colleagues, ladies and gentlemen. Do you have my screen and my voice?
Yes, we can see your screen and we are able to hear you. Thank you.
Thank you very much. I'm Dr. Vosoughi. I am talking to you now from Tehran, Iran. I'm an orthopedic surgeon. Currently, my research foci include hip and knee surgery mostly, and I must say that I'm honored to be among such distinguished lecturers and colleagues. This is my first time presenting a paper in an international conference, and I hope I do not bore you. Nevertheless, it is very hard to follow such great presentations. Thank you. The paper I'm about to present is entitled The Path to Minimizing Instability in Developmental Dysplasia of the Hip. Is capsulorrhaphy a necessity or a futile habit? This paper was recently published in the BMC Journal of Musculoskeletal Disorders, and I'm about to present our findings in this study. First of all, I would like to present some known findings regarding developmental dysplasia of the hip, and step by step, we will walk into our study findings. As you all know, a stable congruent hip is the result of appropriate contact between the acetabulum and the femoral head. And absence of appropriate contact between the two would result in incongruent development of the hip joint. The principal method of treatment in every child with developmental dysplasia of the hip includes reduction of the hip joint and gaining proper stabilization in order to prevent future instability or a recurrent subluxation or dislocation of the hip joint. Our main goal in the children with developmental dysplasia of the hip is to keep the femoral head within the acetabulum in order to provide a stable, congruent hip in the future for the child. There are different methods according to the child's age and severity in order to treat the developmental dysplasia of the hip. But despite various literature and papers on the topic, there is still substantial and high quality absence of papers in the literature. This was mostly apparent in the 2018 survey of EPOS and POSNA members on their preferred treatment methods for developmental dysplasia of the hip joint. And there's a still need for more and high quality papers regarding the preferred and the most appropriate treatment strategy in children with developmental dysplasia of the hip joint. Most surgeons favored prior to 6 months of age. In children which we decide to perform surgical stabilization, this could be indicated in the ones with failed conservative treatment, residual hip dysplasia, and older children are particularly more common in developmental countries such as Iran. And this is a particular issue of interest for us. Surgical stabilization can be achieved by a concentric reduction of the hip joint at first, and then performing capsulorrhaphy and correction of the bony deformities if needed. Correction of bony deformities could include Salter osteotomy of the pelvic bones, the iliac bone, plus femoral shortening osteotomy or derotational osteotomy of the femur. Regarding capsulorrhaphy, there is not absolute agreement between different surgeons. Some believe capsulorrhaphy to be a futile habit. They believe it to be an unnecessary step which can put hip joint in jeopardy regarding range of motion, and could cause unnecessary complications such as risk of avascular necrosis of the femoral head. These are some of the concerns in performing routine capsulorrhaphy in children with DDH. And some surgeons believe it to be, on the other hand, a good adjunctive to other measures in order to provide a stable hip joint. And for example, the paper by Gia et al. In the Journal of Orthopedic Surgery and Research, they use the minimally invasive bikini incision in order to openly reduce the hip joint and stabilize it in children. They used capsulorrhaphy with a specific method, which I will explain later, and they reported acceptable results with safe surgery. In order to understand if the surgery for DDH has been successful, one of the most important findings would be in achievement of a good simple radiograph of the hip joint. And to achieve a low medial joint space would indicate a well deep-seated femoral head in the acetabulum. So we hypothesized that capsulorrhaphy can improve the acetabular head contact among the patients treated surgically for DDH, and we tried to determine if this was true. Our primary objective was to determine if capsulorrhaphy decreased the medial joint space in patients with DDH. We designed a retrospective review of consecutive patients. The best design in order to answer these questions would be to perform capsulorrhaphy in a group of patients and compare it with another group without capsulorrhaphy and compare the results. But as we have experienced capsulorrhaphy to be rather useful, we've thought it might be unethical to perform such studies. So we performed a before-after study in which we included 18 unilateral DDH patients after excluding those with non-idiopathic causes. And we tried to determine the medial joint space just before and just after performing capsulorrhaphy during surgery by the use of fluoroscopy. And we tried to actually determine the answer of our question by radiographically evaluating the hip joint. The procedure constituted of a one-stage open reduction of the hip joint plus Salter osteotomy for all children as they were all more than 18 months old. And in some cases, if needed, the surgeon would perform femoral shortening osteotomy. In none of the cases, femoral derotational osteotomy was needed. Two surgeons performed all surgeries from August 2014 to January 2019. And two intraoperative radiographs was taken as a simple pelvic AP X-ray at supine position. We used magnification marker in a constant position in order to determine the exact medial joint space and compare it between different cases. As you can see in this slide, this is the method we used in order to determine the medial joint space. This is the distance, the parallel distance with the Hilgen-Reiner line between two distinctive points. The first point is the medial edge of the proximal femoral metaphysis, and the second point is the lateral edge of the obturator foramen. We evaluated and decreasing such a space. The surgical technique, as you are all familiar with, included putting the patient in a supine position, performing bikini incision. We didn't try minimally incisions. We tried classic bikini incision, the classic tensor sartorius interval in order to gain exposure on the hip joint. We performed V-shaped capsulotomy in order to gain exposure on the acetabulum. Then we removed the obstacles of reduction, including the pulvinar fat tissue in the joint, ligamentum and the transverse ligament. And after performing a required correction of the bony deformities, we performed concentric joint reduction. After gaining a concentric joint reduction, and just before performing capsulorrhaphy, we performed a simple AP fluoroscopy of the hip joint and determined the medial joint space there. And then we performed the capsulorrhaphy and repeated the X-ray. At last, we performed wound repair with 6 weeks of spica casting, which was switched to 4 weeks of broomstick casting in the future. In this figure, I want to show how we performed capsulorrhaphy in our patients. We didn't perform capsulectomy, to be specific. We only tried to imbricate the capsular margins without removing any of the redundant capsule. We tagged the 2 edges of the capsule first by absorbable sutures, and then we imbricated the capsule. The demographic data of our patients is shown here. The interesting fact is that we had not few patients over 3 years of age, which shows the high rate of neglected DDH cases in our center. We had 7 cases out of 18 which referred to our hospital after 3 years of age for the treatment of DDH. And as you can see here, the mean medial joint distance before capsulorrhaphy was calculated to be 1.5, which was decreased to the amount of 0.7 after capsulorrhaphy, and this was significantly this showed a significant reduction in the medial joint space after capsulorrhaphy. In this table and also in the future figures, I will show the precise detailed medial joint space of every patient. Here you can see an example. On the left, you can see the fluoroscopic image that we took just before performing capsulorrhaphy. We had removed all obstacles of the reduction from the acetabulum. We had performed Salter osteotomy, and then we were able to gain a concentric reduction of the hip joint. At this point, we performed a AP X-ray of the hip joint in constant rotation and position and evaluated medial joint space. And then we performed capsulorrhaphy. And on the right, you can see the medial joint space just after performing capsulorrhaphy. The surgical plate was used as a magnification marker. I believe that this was a limitation to our study. It was better to use a spherical magnification marker. But nevertheless, we tried to put the magnification marker in a constant position so that the angle would not change and the distances would be reliable. We tried to exclude the effect of age in patients, and even after performing such analysis, there was significant reduction of the medial hip joint space after performing capsulorrhaphy. In this bar chart, you can see that each patient, the detailed medial joint spaces of patients before and after capsulorrhaphy is shown. The whole bar, including the blue and orange columns, shows the medial joint space before capsulorrhaphy, and the blue columns show the medial joint space right after capsulorrhaphy. As you can see, in all cases, there was a reduction in the medial joint space, and the mean reduction was calculated to be a significant one. So in order to sum that up, the literature is still scarce with contrasting results regarding the treatment of developmental dysplasia of the hip joint, especially regarding performing capsulorrhaphy. Surgeons perform or avoid capsulorrhaphy regarding their own interest, and there is no definitive evidence in the literature regarding the advantage or futility of such a step in developmental dysplasia of the hip. In our study, we report that capsulorrhaphy independently of age is associated with a decrease in medial joint space. This can show that capsulorrhaphy is effective in achieving a better deep-seated femoral head in the acetabulum, that this could indirectly mean a clinical result of less instability in the future. Of course, we cannot result any clinical definitive evidence from this study, but future studies could continue this work and perform clinical comparison between the two groups in order to shed more light on this matter. I apologize if I be as clear as too well, and thank you all.
Thank you very much, Dr. Vosoughi, for your wonderful lecture.